Moving on to chapter 32, which is musculoskeletal trauma. Kind of our goals here are to review the knowledge of the bones, muscles, and everything that makes up the musculoskeletal system. We want to have a general knowledge for the guidelines of emergency care of these musculoskeletal injuries. We'll go over the purposes and general procedures for splinting, and then that'll be something in hands-on that you'll be able to get to practice some. And then the last thing would be the assessment and care for some of the specific injuries of the upper and lower extremities. So we'll plug through this. It's a fairly short chapter, but there are a lot of slides, and there will be some skills slides that go with this as well. So reviewing the musculoskeletal system here, remember that bones, they're going to be the framework. They're what's going to give the body structure. Bones can break. They do have a self-healing nature. So when they do break, as long as it's a simple fracture, they are able to heal on their own. That's when you see people getting casts. If they are compound fractures, more complicated fractures, sometimes they will require surgical intervention to put them back together. The other thing to remember with bones is that they are very vascular. So when you break a bone, they can and will bleed. So some bones, the pelvis, the femur, the long bones, if you break those, the patient can have significant blood loss with this. So that's always a concern when you're in the EMS setting and you see this. Now, joints are going to be the places where these bones meet and gives the body the ability to articulate and the ability to move. So any place where you have movement, elbow, wrist, fingers, all over your body, those are made up of joints. You can break bones in joints from an EMS standpoint. The bigger thing that you're going to see is dislocations of these joints, of which, generally speaking, we will not put them back in place. You will splint them, get them to the hospital so that they can be properly put back into place. But that's what you will see from the EMS standpoint. Third thing on the list here, muscles. And those are the tissues and fibers that cause movement of the body parts or organs. So remember that there are three different types of muscles. The smooth muscle, which is the involuntary muscle, so the muscles that you do not control, like the walls of the organs and digestive structures. Then you have the cardiac myocardial muscles, and those are found in the walls of the heart, and they're what controls the heart and the heartbeat. And then the last one are the skeletal muscles, which are the voluntary muscles, and these are the muscles that you control and you use for movement. A few more items to review here. Cartilage is going to be the connective tissue that covers the outside of the bone, and it acts as a surface for articulation. So it's kind of a padding, in a sense, for the bones. So as people get older, that cartilage will break down, and this is what arthritis causes. This is why you have joint pain, is usually because of a breakdown of that cartilage. So you will see some patients sometimes that have this severe cartilage issue that you may transport in the ambulance. Tendons are going to be the bands of connective tissue that bind the muscles to the bones. You can rupture tendons. It's not all that uncommon in athletics to see a ruptured tendon. And then ligaments are the connective tissue that supports joints by attaching the bone ends. So this is what holds bone to bone. And again, these ligaments can tear. You will see this a lot in sports-related injuries. Like the knee, you'll see ACL tears, MCL tears, UCL tears in baseball pitchers, tears through the shoulders. So it's not that uncommon that you may see some of these as well. The bones are actually formed of dense connective tissues and like we talked about, they can break. It's very important to understand the splinting processes and to get these broken bones splinted um, as as quickly as you can through the assessment process. The goal with this is to limit further damage potentially because where you have these breaks, you can lose blood, and then that can lead to cell death in there potentially as well. So that's why we splint things, is to keep them in place to prevent further injury. Like we talked about, they are very vascular, so they are susceptible to bleeding or injury. The larger bones being the pelvis, the humerus, the femur, those will bleed a significant amount potentially, so you could have to be prepared for shock in these type of patients. And then the bones are covered by what's called the periosteum. Now joints are going to be where those bones meet. So anywhere where two bones meet is going to create a joint. Bones are going to be classified by the shape of the bone. So the first one being the long bones, which are going to be, as they sound, the longer bones in the body. So the bones of the arms and the legs would be considered long bones. Short bones, again, as it sounds, will be the short bones of the body, and those are going to be the bones located in places like the hands and the feet. Now the flat bones are going to have a flatter surface, and therefore when you think of things like the sternum, the shoulder blade, and the ribs, those are all considered flat bones. Irregular bones are bones that don't meet a specific shape. So when you think about an area like the vertebrae of the spinal column, that's going to be your example for irregular bones. As I mentioned earlier, bones do have a self-healing nature. So basically, that break is going to cause that soft tissue swelling, and like we talked about with it being a vascular area, it's going to bleed, um, and then it's going to cause a blood clot in the fractured area, hopefully. Otherwise, you can have blood loss from a fractured bone. If there's an interruption in that blood supply, it can cause the cells to die at the injury site. Cells further from that fracture rapidly divide, forming tissue that heals the fracture and develops into a new bone. So the body's mechanism is basically that when you break, the cells are going to start dividing, and when those cells divide, that's what forms this new tissue. And then over a period of time, new bone will actually develop over top of where the fracture was and fuse everything back together. So depending on what bone you fracture, where the fracture is, will depend on the time frame it takes for that bone to completely heal and get back to one solid structure. And we've already talked about this in an earlier slide. So just remember the three different kinds of muscles being skeletal, smooth, and cardiac. And then like we talked about, that cartilage helps form flexible structures of the body and gives cushion to the joints in different areas of the body as well. Again, also discussed already, but reviewing, tendons are muscle tendon bone, so they connect the muscles to the bone. Ligaments are bone ligament bone, so they connect bones to other bones. Now moving into the general guidelines for emergency care. Um, the first thing we're going to look at here is the different mechanisms of musculoskeletal injury. So the first one being direct force, exactly as it sounds. Direct force puts enough pressure or compresses the bone um, in a sense that it can cause the fracture. Twisting or rotational forces, those are going to be the ones that cause a portion of the body to abnormally twist or rotate. So think of a basketball player going to plant to make a cut, and the leg gives out and things turn the wrong direction. That's going to create that twisting rotational force. Now these can break bones, but they will also be the kind of injuries that will tear and rupture tendons and ligaments. An indirect force is usually a result of a direct force. So your book uses the example of somebody jumping off of a roof. The direct force will cause the damage to the initial impact point, which is going to be your feet, ankle, lower bones on your lower legs. And then an indirect force can be caused if there's enough pressure moving up the body that creates injury further away from the impact site. So think of somebody that has a compression fracture in their spine. It is probably some sort of indirect force that caused that spine to compress all of a sudden, which causes the fracture. So that is what an indirect force is. So injuries to those bones, first thing to understand is a couple different types of actual fracture. So the first thing to know is that any break in a bone is considered a fracture. And these breaks can be open or closed, just like previous trauma chapters. Open is where the fracture is going to be exposed, and you will be able to visually see it. A closed fracture is when the skin is still intact, and you're not going to be able to see that fracture. You will have to get sometimes you're going to understand and know it's broke by looking at it, even though it's a closed fracture. More times than not, it's going to take an x-ray to be able to see the actual fracture. Now, a few different types of fractures here. The first one being a comminuted fracture, which is where the bone is broken in several places. The second one is going to be a green stick fracture, which is an incomplete break. And when you think about this one, it's common, especially in children, because their bones are still a little bit more pliable than those of an adult. So it's not uncommon for them to have green stick fractures. And think of early in the summer, late in the spring, if you try to snap a branch off of a tree and it doesn't really want to snap, it more kind of bends and maybe cracks. Think of the green stick as it's like literally a green stick that's hard to actually break completely. And then an angulated fracture is when the bone is going to be bent at an angle. Moving on to some more injuries to the bones, and this is going to be more of your physical therapist type of information here. A dislocation is going to be where that joint comes apart, like we talked about earlier. So you can dislocate any joint, it doesn't matter if it's your ankle. Your kneecap is a very common one that you will see. Dislocations of the shoulder are actually very common from an EMS standpoint as well. Sprains are going to be stretching and tearing of the ligaments, whereas strains are going to be overstretching or overexertion of the muscles. So sprains are ligaments, strains are muscles. And then last slide here on injury to the bones. Remember that not all these injuries can be confirmed as a fracture in the field, and at the end of the day, it doesn't matter. You want to treat all of these injuries that have the signs and symptoms of a fracture as if they are a fracture. It doesn't matter if it's a sprain or a strain or a fracture. The treatment that you provide for these patients is going to be the same to get them to the hospital. Most importantly is going to be splinting of the extremity with the suspected fracture. This is going to help prevent blood loss and help prevent further damage to the affected area. A traction splint is actually going to be a specialized splint that we use for suspected femur fractures. It's not that uncommon to have femur fractures, and you want to make sure to use a traction splint because remember that you can have more blood loss from a femur because of it being a long bone with a lot of vascular structure in it. A traction splint is basically going to pull that lower leg away from the torso of the body, and it's going to align that femur up better and keep it aligned through the transport to hopefully minimize that blood loss. Now, as we look at the primary assessment, when we're looking at the assessment of these musculoskeletal injuries, make sure to rapidly identify and treat life-threatening conditions. So this is something that you should be doing in that primary assessment while you're doing the ABCs. You should be able to recognize these, and then you stop and correct any life-threatening conditions. Be alert for injuries besides those grotesque wounds. So it's easy to get caught up on the blood and gore of an injury, and it's easy to overlook something that may be a life-threatening injury as compared to these grotesque wounds. The grotesque wound may not be life-threatening, so don't get tunnel visioned on them. Make sure that you're doing a proper assessment so that you can identify the life-threatening conditions. This is a thing where you are going to want to cut or remove the patient's clothing so that you can adequately examine to fully understand the severity of the situation. So it can be a little bit awkward and uncomfortable, but depending on where the injuries are is going to dictate the amount of clothing that you cut off. And if a patient is in a bad enough car accident and they have significant pain all over the place, you may be cutting all of their clothes off. So you can be put into an awkward position where the patient is very uncomfortable, but it may be a necessary evil so that you can fully assess and properly assess. The important thing here is to communicate so the patient understands what you're doing and why you're doing it, and to not cross the boundaries of exposing more than you really need to. If they have a leg injury, you don't have to cut up and cut all the way through their underwear and everything like that. It can be inappropriate if you do cross that boundary. So there is a fine line there of what needs to be exposed and what doesn't need to be exposed. But there will be times that the patient just needs to be fully exposed. So this is very subjective and a judgment call, and you just have to use your best judgment in these situations. Compartment syndrome is actually going to be a very dangerous condition for the patient because it can ultimately and potentially cause the limb to be lost. So basically, it's when there's a fracture or crush injury that causes bleeding and swelling to the extremity. That pressure and swelling then becomes so great that the body can no longer perfuse. So basically, you've created an internal tourniquet with all of this pressure. So when that happens, just like putting a tourniquet on, that cellular damage can start to occur, which kind of has a snowball effect in the aspect that it's going to cause additional swelling. Now, if blood flow is lost to the area and not restored in a timely manner, just like putting a tourniquet on a patient, that limb may be lost. So what is it that you do? The signs and symptoms are going to be similar to those of any injury that you might see to the extremity. You're going to see significant pain and swelling. They're going to generally complain of a sensation of pressure distal to the injury site. And the extremity may feel hard on palpation compared to that of the uninjured site. So make sure that when you're assessing these patients, that you're not only assessing the good side or the bad side, but you're also assessing the good side with it, because that gives you a comparison. And this goes for any musculoskeletal injury. Compare the bad with the good to see if there's differences, to see if there's deformities, so that you can see if there's something abnormal there. How do you treat this compartment syndrome? You're going to treat it the same as any other fracture. So cold application, elevate the extremity. Those can be done after you properly splint the extremity. If you're concerned about this, prompt transport to an appropriate facility is also very important so that they can get it taken care of. In the hospital, there are things that they can do to potentially relieve some of that pressure. But these patients a lot of times are going to end up having to go to the surgical to have it taken care of. From a general standpoint, as you assess the patient, some of the things that you're going to look for are obviously going to be pain and tenderness. Make sure that you are palpating appropriately so that you can determine that pain and tenderness. Make sure that you're getting an assessment of the pain on that scale of 0 to 10 to determine the amount of pain the patient's in. We're looking for deformities and angulation. These are going to be obvious signs of a fracture or dislocation. Grating or crepitus is actually going to be when there's a fracture and those two bone ends are actually kind of rubbing against each other. So imagine taking two hard surfaces and rubbing them against each other. That grating sound that you're going to get is what's called crepitus. You will see swelling and bruising in fractures, but you may also see swelling and bruising in strains and sprains as well. If it's an open fracture, you may see an exposed bone end that has actually penetrated the skin, but as the picture earlier in the slideshow showed, you may also see exposed bone ends that have not protruded through the skin surface yet. Those will also be obvious signs of fracture or dislocations. Another thing that you potentially could see is where the joints are locked into position. So for example, it's not uncommon when somebody dislocates their kneecap, now they can no longer bend at the knee like they normally would. So that joint becomes locked into position, telling you that there is some obvious damage, whether it's fracture or more commonly some sort of dislocation that's not letting the bones hinge or rotate within the joints like they should. And then the last thing here is the potential for nerve or blood vessel compromise. And the way that you're going to want to evaluate this is through what we call PMS, which is pulse, motor, and sensation. So wherever the injury is, you want to go distal. So if they have a broken forearm up towards their elbow, you want to go down, make sure you're checking a radial pulse. That's going to tell you that the blood is flowing. Have them wiggle their fingers so that you know you have motor function, and then kind of pinch almost like you're doing cap refills on their fingers to make sure that they have sensation. And that is one way to check for the nerve and blood vessel compromise. A helpful acronym are the 6 P's of the assessment, and what we're looking for here as you palpate and assess the area are going to be first, pain or tenderness, which is self-explanatory. Pallor is going to be where you have pale skin, which is going to be due to poor capillary refill. Paresthesia is going to be the pins and needles, so they're going to have that tingling feeling distal to the injury site. Pulses, which like we talked about in the last slide, you want to make sure to check pulses distal to the injury site to see if they're diminished or absent. Those would be indicators of a bigger issue going on at the actual injury site. Paralysis, which is going to be the inability to move the injured area, and then pressure. Do they feel any pressure more so than normal to the injured area? Moving into the patient care setting here, the first thing is going to be obviously make sure that we're taking our standard precautions. Secondly, don't get caught up by how things look. Make sure that you do the primary assessment first. Doesn't matter if they're missing a leg. Doesn't matter if all their extremities are bent in different positions from what's normal. If they're not breathing, nothing else matters. So make sure that you perform that primary assessment, which should only take you a few seconds, so that you can identify and take care of any life-threatening conditions. Then you'll move into that secondary assessment, and this is the point where if you suspect a cervical spine injury that you're going to apply the C-collar. Now you're going to move into the extremity areas where you might find fractures after you've treated the life-threatening conditions. You want to, at this point, splint any of those suspected fractures. Make sure you're checking that PMS previous to splinting and then rechecking it again after you splint. and then cover any open wounds with sterile dressings, and control any bleeding that may be occurring with it. We've talked about splinting a couple times now throughout the chapter, and so what is splinting, and really right now, what are the advantages of splinting? So the first thing is it's going to minimize the movement of the disrupted joint and bone ends, broken bone ends. So you're going to prevent further damage from occurring by applying a splint to these areas. It's also going to decrease pain because you're going to keep those nerve endings hopefully in position. The pain is going to be caused from the broken, affected area rubbing over those nerve ends, causing the pain. Hopefully by splinting, you're going to keep that all more aligned, and that's going to decrease the pain level for the patient. Like we talked about, it's going to prevent additional injuries to the soft tissues, so things like the nerves, arteries, veins, and muscles. The goal is to prevent further injury to those areas. It can also prevent a closed fracture from becoming an open fracture. So again, go back earlier in the slideshow to that very grotesque ankle deformity. Without splinting that, there is the possibility that just the jostling of transport to the hospital could put enough pressure that allows that bone to actually now protrude through the skin. And what you've done by doing that now is created an open area, and now you have to be concerned about the risk of infection. The other thing it's going to do is minimize blood loss. The goal is to, again, get the bones in affected areas lined back up, and when doing so, hopefully that will help the areas that are bleeding to clot off, and minimize the amount of blood that the patient loses. There may be times when you get to the scene of a badly fractured or dislocated area in which realignment of that deformed extremity is going to be needed. These are going to be rare because generally speaking, as long as there's good blood flow, good PMS distal to the injury site, we are just going to splint it in position, transport them to the hospital, let them get some x-rays, and then let the doctor make a determination on what the treatment's going to be. But if you have to realign this deformed extremity, what it does is assist in restoring effective circulation to the extremity, and it'll simplify the splinting. If you don't realign it, that splint may become ineffective. It may cause further pain and cause further injury. So if you're worried about circulation distal to the injury, that's when you're going to be thinking about realignment here. I'm going to skip to the bottom segment of this slide first because it's the thing you have to understand before you worry about realignment. And that's if the extremity distal to the injury is cyanotic or lacks pulses, that is going to require the need for realignment. So you're going to align the joint back into the neutral position, or as close as you there can, using gentle traction. So you're going to basically, let's say that they have a badly broken ankle and they have no pulse in their foot, they can't wiggle their toes, they can't do anything like that. The foot's becoming cyanotic. If you don't do anything, they potentially could lose that foot. So in this situation, you're going to need to realign the ankle to restore blood flow. And what you're going to do is basically take hold of the affected area distal to the injury. You're going to pull it away from the injury site gently, and then in the hope that it's going to realign things back into that neutral position. It's going to cause increased pain initially for the patient, with the goal that it's going to actually decrease their pain in the long run, because the nerves and arteries and veins aren't being compromised anymore. So once you realign, you're going to want to still splint it. But as long as they have pulses, they can wiggle their extremity distal, you're just going to want to splint it in the position that it was found in. and then kind of continuing on the actual realignment process. So it's going to be a multiple person job, but you're going to want to have one person grasp it distal while the other person stabilizes it above the injury site. You're going to gently pull manual traction in the direction of the long axis of the extremity, so generally away from the injured site, kind of on a straight line from the injury site. If you don't feel any resistance, because you want to make sure that you're not causing more damage. So if you don't feel resistance, continue to pull until things properly align. Like I said, you're going to feel some popping and cracking and potentially even some tearing as things line back up. But that is what the goal of this is going to be. Once you get it realigned, like I said, splint, make sure to check PMS. Hopefully at this point you've restored a pulse to the area and you'll start seeing the color come back to the area. So looking at the strategies for splinting, the first thing to remember is that effective splinting, it may require some ingenuity and really creativity as well. If there's 8 different EMTs splinting the same injury, you may have 8 different strategies for applying that splint in place. And you may have different kinds of materials being used to put those splints in place. So the first thing that you're going to look at is what type of splint do you want to use. So the first one is going to be a rigid splint, which is going to basically be exactly as it sounds. It's going to be something rigid. So we use what's called ladder splints. They can be a little bit manipulated, but generally speaking, they're going to hold that in place with whatever rigid splint you're using. The next one is going to be formable splints, so you're going to be able to kind of manipulate the splint around the injured site so that it's best used. The common one I think of here is what we call a SAM splint. So it almost feels like a rubbery material with like a cardboard in it, but it's bendable, and when you bend it, it molds to whatever shape you mold it to. So you can actually take this and mold it right around the injured site and do different things with it. The last thing is going to be a traction splint, which is going to be a splint that puts in place that's going to gently pull the distal area away from the injured site to put traction on the area and try to align the injured area back into place. Some more strategies here again is going to be obviously first, care for life-threatening problems first. It doesn't matter if their lower leg is broken and their heel is pointing towards their chin. If they have a life-threatening problem, that's the main concern. So take care of any life-threatening problems first. Secondly, like we talked about, expose. So make sure that you're exposing that injury site so that you can properly assess it, so that you can also properly splint it. I've been talking about PMS, which is pulse motor sensation. They actually call it in your book CSM, which stands for circulation sensation and motor. So it's basically the same thing, but you want to make sure that there is a pulse, motor movement, and sensation distal to the injury. If possible, you want to make sure to line any long bone injuries into the anatomical position. This is going to help prevent blood loss and hopefully decrease the amount of pain that your patient is having. Now, if you do have an open fracture, one thing you do not want to do is push any protruding bones back into place. You want to control the bleeding and you want to splint it as it is. When you splint, you want to make sure to immobilize both the injury site and the adjacent joints. So let's take, for example, you have a tib-fib fracture of the leg. That splint should run from locking it in from the ankle all the way up to the knee. So your joint below the injured site to the joint above the injured site. You want to make sure to choose a method of splinting, and again, this is where your ingenuity and your creativity will come into place. Everybody is going to have different splinting techniques that they utilize, but the long-term goal is that you get it splinted above and below the injured site and keep it into place. And it doesn't matter how you get to that end result. You do want to try to splint before you move the patient to the stretcher or any other location, if at all possible. Sometimes you won't be able to, more times than not you will. But again, if you don't splint it and you're moving them around, this can create more damage, can create more blood loss. So the goal is to get it splinted so that you can prevent that further injury. If you have any voids while padding, while splinting, you want to make sure to pad those voids. So a lot of rigid splints that don't conform to the body's curves, it's going to allow some movement in there. So if there are any voids or spaces between the body part and the actual splint, you want to make sure to pad those and try to secure them in place best you can. So looking at splinting and what are some of the concerns or hazards of the splinting that you need to be thinking about as you're working through the process. The first one is splinting the patient to death. And we've talked about it a few times in the chapter, but this is when you get too caught up on the visible injuries and you forget about the life-threatening conditions that there are. And so basically, you get caught up on splinting the injuries that really don't mean anything in the patient's life at that point, and you forget about the fact that they have airway compromise and now they've died because you didn't take care of the life-threatening conditions first. With any call, most importantly are the ABCs. So you have to make sure that you go through that initial assessment, primary survey of the patient, and the first thing in that is going to be your ABCs. The next two things here are too loose, too tight. And if you splint the area too tightly, you've basically created a tourniquet and you've compressed the soft tissue, which you can cause more damage with. If you splint it too loosely, your splint's not really serving any purpose. You may as well not put it on, and it's allowing too much movement, and now the injured area can cause more damage when it does jostle around and move some. So it's important to check that PMS, CSM, whatever you want to call it, the pulse motor sensation, before splinting and after splinting. Another hazard is splinting in a deformed position. So you want to make sure that you are realigning that injury to the anatomical position and getting things where they need to be as long as you properly can. Moving into splinting long bones or joint injuries. Again, first thing, standard precautions. Second thing, expose the area so you can properly assess. Third thing is going to be manually stabilize the injury site. So while your partner is getting the equipment ready to splint it and keep it in place for transport, you can manually hold that into position and stabilize the injury site. And then just as the other injuries, dislocations, fractures, you're going to assess that CSM, PMS, however you want to call it. You'll want to do that prior to splinting, and then you'll want to do it again after splinting. You're going to want to realign that injury if it's grossly deformed or if the distal area to the extremity becomes cyanotic or pulseless. Again, that's going to be just as we talked about previous. You're going to want to measure. There are going to be different size splints that you can use, so make sure to measure, use the appropriate splint or adjust it if it's adjustable so that it can properly hold the affected area into position. And then you're going to want to apply and secure the splint to the immobilized injury site and then adjacent joints. So like we talked about before, the joint above, the joint below the injured site. And then once you have the splint in place, again, check that PMS or the circulation sensation motor distal to the injury. Make sure that you have it properly in place. As discussed earlier, the traction splint is going to be specifically for femur injuries, which is the long bone in the upper leg. There are generally going to be two types of traction splints you can use, bipolar and unipolar. So just as anything, break down the word here. Uni means one, bi means two. So the bipolar splint cradles the legs between two metal rods. A unipolar splint is going to have a single metal rod that runs along the outside part of the leg. Now the amount of traction or force that you want to use pulling the affected area away from the injured site is going to be roughly 10% of the patient's body weight, but not exceeding 15 pounds. Now most of the traction splints, actually all of the traction splints that I have used, it's not like there's a measuring guide on there to tell you when you've reached 8 pounds of pressure. So there is still a little bit of judgment, but basically the moral to this is when you put this traction splint on, don't just pull and pull and pull as hard as you can because you're going to be putting too much traction on the affected area and you can actually cause more injury. The goal of this is to stop any muscle spasms that may be occurring, line the bone back up into place, hopefully control the bleeding and reduce the amount of pain the patient has. As we move through the different kind of splinting techniques specific to individual injuries, they're going to be pretty much the same for a lot of the components. So again, standard precautions: expose the area that needs to be splinted, manually stabilize the leg. You can hold on to the patient's ankle and gently manually pull traction and try to line things up. Assess that CSM, PMS, distal to the injury, and then adjust that splint to the proper length and position it under the injured leg. Traction splints are a little bit cumbersome. They can be a little bit tricky to put together. You are going to work in the sensitive groin area of your patient with these as well to get them secured. So be professional while you do this. It's going to be a multi-person job. These splints are going to have different securing devices that you're going to need to put in place. So you're going to apply the proximal securing device. So the securing device that is going to wrap around usually the upper part of the leg and kind of wrap around into the groin area called the ischial strap. And then you're going to apply the distal securing device, which is the ankle hitch. You're going to want to apply mechanical traction and then position and secure these support straps. So basically you're going to get these straps on, you're going to have the rods in place, you're going to pull the traction in, and then you're going to attach it to the straps. Luckily for us, we actually have both the bipolar and unipolar traction devices, so when we do the hands-on, you will be able to see both of these and practice both of these. Once you have that splint in place, make sure that you reevaluate the proximal and distal securing devices and reassess the CSM distal to the injury. You will want to keep an eye on this throughout your transport to make sure that it doesn't come loose and the traction becomes less. you want to just make sure to keep an eye on things. Secure the patient's torso and the traction splint to a long spine board to immobilize the hip and to prevent movement of the splint. So basically you're going to put this patient on a long spine board so that way everything stays locked in as one unit. Now moving into specific injuries. So the first one is going to be shoulder injuries. And when you assess, you should see pain in the shoulder. You may see a drop in the shoulder. So if you're looking at them face to face, you're going to want to compare the injured site to the uninjured site. And what you may see is that that shoulder has actually dropped and hangs lower than the unaffected side. A lot of times these are going to be caused by a severe blow to the back, kind of over the shoulder blade area, and it can cause that shoulder to dislocate or some of the bones in there to fracture as well. Again, assess that CSM, PMS prior and after you take care of this injury. With these injuries, you're going to want to use what we call a sling and swath. And basically it's going to be a cloth material that you're able to kind of secure their lower arm, and then it's going to go and be held in place over the neck of the patient, and then you can actually take and wrap ACE wrap or another material kind of around the body to hold the arm in place against the body. If there's evidence of a anterior dislocation of the head of the humerus, so if you see that humeral head kind of poking out on the front part of the shoulder, place a pillow between the patient's arm and their chest. With shoulder injuries, do not attempt to straighten or reduce them. It is very complicated to get shoulders back in place usually. So you want to secure them in place, get them to the hospital so that they can properly be sedated and then have it put back into place. Once you get all of this done, again, make sure you're checking that CSM, PMS, and make sure that everything is okay. If you have to, you may need to make some adjustments. Moving on to the pelvic injuries, and like I talked about a couple times earlier in the chapter, the big thing with pelvic fractures that you have to be concerned about is the vascular area and the amount of blood loss that can occur with it. You will have pain in the pelvis, hips, groin, or back. When you do the assessment, make sure that you compare left side to right side. Pelvises can be a little bit challenging to assess if you don't do it properly, especially. So make sure that you're actually palpating gently and you're comparing good side to bad side. They will probably have increased pain when you do apply that pressure to the iliac crests, and more times than not, they're going to not be able to move the affected leg. So they won't be able to lift that leg when they're lying supine. Many times you will be able to walk in and look at them and almost be able to see that there's probably a fracture of the pelvis because their leg is going to be, their foot will be rotated out, and a lot of times their leg will appear shorter than the unaffected area. They may have unexplained pressure in the bladder because when it fractures, it displaces things and can put pressure in the bladder, which in the same sense you may also see some bleeding from the urethra, the rectum, or the vaginal opening in these situations. Try to move these patients as little as possible. Determine the PMS CSM distal to the injury site. Attempt to straighten the lower limbs into the anatomical position. Again, you may cause increased pain initially, but the goal is to cause decreased pain and minimize blood loss long-term during your transport. Stabilize those lower limbs into place, and then you will also want to assume that there are spinal injuries with these patients potentially, so make sure that you're properly assessing the spine. Um, Pelvic injuries are a good place that you can use what's called the scoop stretcher um, to get them moved from where they are laying onto the cot. Basically, the scoop stretcher is a unit that comes apart into two pieces, and it does exactly as it sounds. You're able to put those back together by scooping up underneath the patient. It allows for very limited actual movement of the patient from where they are laying, so it's going to be probably the lowest amount of pain in the movement process for them. If your protocols allow, they also have pelvic binders these days, which kind of secure and hold the pelvic girdle into place by it's basically a tight band around that pelvic girdle to splint it into place. Again, once you have things put in place, reassess the distal CSM. You're going to want to do that throughout transport. And these are the patients that you need to be prepared for shock. Like we talked about, you can lose a significant amount of blood through pelvic injuries. So be prepared, be monitoring vital signs, provide high concentration O2 to these patients. Try to get them transported as soon as possible, so limit scene time, rapid transport, and then monitor those vital signs throughout your transport. Make sure to get your baseline vitals so that you can trend that data and almost kind of predict if the patient is becoming shocky. Like I mentioned, and it's going to be a few slides here showing you what these pelvic wraps are. Or pelvic binders is what I had called it. There are commercial available devices, pretty common out there. You can also do this in a creative manner utilizing a sheet, but basically it's applied to a patient who has that pelvic deformity or instability, and it doesn't matter if they've got signs or symptoms of shock. Because the goal of this is to splint that pelvic girdle into place and hopefully prevent them from getting to the point where you have to be concerned about shock. Couple slides on hip dislocations. This is going to be a common call, especially with your elderly patients that you will find in the EMS world. With your patient assessment, you may see an anterior hip dislocation, which you should be able to palpate and feel. You may see a posterior hip dislocation, of which you will find that there is a rotation of the leg inward and the knee is usually bent. Again, shortened and rotated is what we call it. The foot may hang loose, and they're going to be unable to flex that foot or lift their toes. They may also have a lack of sensation in the limb if the nerves are compressed or pinched in any manner. Again, as always, assess that distal CSM prior. Move the patient to the long spine board. Immobilize the limb with pillows and blankets. So you're basically using the spine board as your splint. You're patting the voids and trying to lock that limb into place utilizing the pillows and the blankets. Secure the patient to the spine board and then reassess that CSM. With any hip pelvic injury, be prepared for shock because of the blood loss. Transport, monitor those vital signs, make sure to get baseline vitals so that you can monitor a little bit easier for the signs of shock. And then check for any nerve or circulation impairment. Communicate any of the findings that you may have when you give your radio report to the hospital. And a little bit more on hip fracture from a patient assessment, which a lot of this is going to sound familiar. but the pain is generally localized to the affected area. When you are palpating the area of the greater trochanter, they are going to be extremely sensitive to the pressure of that palpation. You may see bruising of the soft tissue in the area, but you also may not as well. Swelling may be evident depending on your patient as well. Usually they will be unable to move the limb while they're on their back. They're not going to be able to stand. They're not going to be able to bear weight. They're not going to be able to ambulate. The foot on the injured side is usually turned outward, and the limb appears shorter. The way to properly care for this is you're going to place a folded blanket between the patient's legs and bind the legs together with wide straps or wide cravats. The next image is going to kind of show you a little bit what they're talking about. Use thin splits to push those straps under the patient and at the natural voids. So you don't want to be lifting and moving, jostling the patient more than you have to. Try to limit that and try to get the straps pushed through this method. And then readjust so that they'll pass across the chest, the abdomen, and just below the belt. Below the groin area, and then above and below the knee and at the ankle, and try to secure them in as best you can and keep their entire body as stable as possible. We've talked about the femoral shaft fracture a little bit, but they will have intense pain. It may or may not be an open fracture, depending on the mechanism of injury and how it became fractured. The injured limb may be shortened, especially if that femur is displaced, and a lot of times what will happen is that femur will displace and then kind of overlap each other. And when that happens, the limb becomes shorter because you've got overlapping bones. For the patient care, if it is an open fracture, first things first, control the bleeding, take care of any life-threatening conditions, be prepared to treat these patients for shock. Like we've talked about a couple times, femur fractures can also cause a great deal of blood loss in rapid time. Assess that distal CSM prior and after applying the traction splint. It's talked a couple different times in here about sizing the splint. So just a little pediatric note, understand that not all traction splints are one size fits all. So make sure that you're using appropriately sized splints. Otherwise, it may be counterproductive and may cause more injury or damage to your patient. Continuing down the body to the knees, as far as the patient assessment goes, you will see pain, tenderness, swelling. You may see a deformity with swelling. Make sure you're comparing the good side to the bad side. So this may be one of those situations where when you're exposing, you may have to expose even the good limb so that you can have a better understanding through the assessment process of what's normal and what's not normal on the patient. As far as patient care goes, again, CSM, PMS, prior and after immobilizing, and then you want to immobilize the knee in the current position that it is in. And further down, the tib-fib fractures, again, pain, tenderness, swelling, possible deformity. You just have to go through the assessment process, compare the good side to the bad side, see what's normal, what's not normal. As far as the patient care goes, this is a good area for vacuum splints or air splints if you have them, but you want to immobilize the fracture basically all the way up to the knee. You may also be able to utilize 2 rigid board splints, one on each side, to secure it in place, or you may be able to apply a single splint that has an ankle hitch. We have blue foam splints that basically it's like a foam boot per se, that goes all the way up to the knee, and then you wrap it tight and it holds it in place. So a lot of what's going to dictate this is what you have for equipment in your ambulance, and or the creativity of what you have at hand to do the splinting process. Now down to the base of the body, and we're looking at ankle and foot injuries. Again, with anything else, you may see pain, you may see swelling, you may see a deformity. Make sure you go through the assessment process. Make sure you're comparing the good side to the bad side. As always, assess that CSM, PMS, whatever you want to call it. Stabilize that limb where it's at. If you have good CSM, then you are going to want to splint it in the position that it's in. You're going to lift that limb, place the cravats under the ankle, lower that limb down onto the pillow, and then tie the pillow around the ankle. The best way to splint ankles in all of the years of experience that we have is with a simple pillow splint. So basically you're going to wrap a pillow around it and secure it in place. It's going to hold everything in place, but it's also going to cushion the area for the patient's comfort. And then tie yet another cravat around the arch of the foot, fully securing it into place. Elevate it with a second pillow or blanket. Reassess that CSM, and remember to continue to reassess through your transport. Care for shock if needed. Generally speaking, with ankle injuries, shock is not a big concern for you. You may also apply a cold pack to help with the swelling, and it can also help with the pain for the patient. Now moving up to forearm, wrists, and hand injuries. Again, you may see deformity and tenderness. You may see pain with any of them. With the hand, you may also see dislocated fingers as well. Again, use your assessment strategies. Assess the good areas from the bad areas so that you can identify what's normal and what's not normal. And this gets us to the conclusion of chapter 32. Go ahead and look through the chapter review. We'll get the next 2 lectures up so that the unit can be complete, and that will get us through trauma once we're through the next couple units here. The big thing to take from this is your assessment, understanding there's a lot of similarities to all of these injuries that we've talked about. Make sure that you are appropriately splinting the affected areas into place. And again, it basically comes down to your ingenuity and your creativity when you're splinting things. Use the tools that you have at hand, but also understand that there's no real specific right or wrong way per se to do this. I've been in areas where we've had a dislocated knee, and basically all we had was some cardboard boxes. You can manipulate cardboard into a splint. Just utilize whatever you can to properly splint and try to limit the amount of pain, the amount of blood loss, prevent further damage for the patient. But we'll continue through the trauma chapters. If you have any questions, make sure to let us know.